Good afternoon, everyone. Welcome to our Quality Forum. Our Quality Forum is part of our Quality and Safety Week celebrations, which are held annually at Hinduja Hospital, Mumbai. And today, too, we have exciting panel discussions with eminent speakers, national and international. Someone once told me some time back, and this applies to all quality managers, that if you want to convince your management that all the quality improvement projects and initiatives you're doing are worth it, show them the money. So that comes to our first topic of the day, translating quality outcomes to financial outcomes. I'd like to introduce Mr. Joy Chakraborty. He's our Chief Operating Officer, and he's also the moderator for the session, himself a champion of quality. Mr. Joy, request you to introduce the panel.
Thank you, Preeti, and good afternoon, good morning, good evening, because we have few delegates from across the globe, and thank you for joining here. And as Preeti has mentioned, that PD Hinduja Hospital is celebrating the 7th year of Quality and Safety Week, and it is very important keeping the quality healthcare for all, the vision of our founder in mind, and how do you inculcate and practice quality and safety for your patients and other stakeholders. So this is one of the very important and interesting session. Every year we organize this quality forum. In this quality forum, we have people from different institution and organization, and keeping the theme of our week, Quality Safety Week, we organize some panel discussion, and we try to get the best of the best faculty speakers to join in this panel discussion and share their views. So keeping the topic of translating quality outcomes to financial outcomes, we also have three distinguished speakers today. We have Dr. Narottam Puri, Professor Dr. Atul Mohan Kochar, Mr. Gautam Khanna. I'll introduce each one of them shortly. And ultimately the goal of this session, what we are trying to see and hear, that how improvement in quality can help us to achieve these financial outcomes. So we are going to start the discussion. So I'm going to introduce Dr. Narottam Puri. I'm sure that those who are present here, you may not require any introduction of him. He is the advisor medical operations and chairman Fortis Medical Council. He is the former chairman of NABH and member of governing board of Quality Council of India. Dr. Puri has spent 5 decades in healthcare as a teacher, as a clinical practitioner, and healthcare administrator. He has experience of government service, not-for-profit, corporate, as well as entrepreneurial parts of healthcare, with expertise in healthcare strategy, healthcare quality, and safety and health insurance. But I can only tell that my contemporaries, many of us probably considered him as our teacher, and we have seen his operations, we have seen his leadership when we joined in this healthcare management field. And the other identity, probably many of you will recall that during our childhood days and all, he used to be in the commentary of cricket and other sports, and his voice, we remember that he used to be there. And when I met him in the healthcare field, it was a really surprise that the same gentleman is here in this sector too. So with this introduction, welcome Dr. Puri. Now I introduce Mr. Gautam Khanna, CEO PD Hinduja Hospital and MRC. He is in Mumbai, an inspirational business leader. Mr. Khanna, in his 32 years of rich experience, has successfully managed diverse businesses and created sustainable shareholder value in challenging environments at PD Hinduja Hospital and 3M. So welcome, Mr. Khanna. And I'll hold on for Dr. Kocher to join, and at that time, I'll introduce him too. So with this brief introduction, I'm moving on to our panel discussion, where I'm going to ask first to Dr. Puri that, you know, after the accreditation and the quality journey and quality initiatives, very often we look at that how it is translating into financial outcomes, how an organization is going to be benefited by taking up this kind of quality initiative. So the question is, how would you translate the quality outcomes to financial outcomes? And is there a special formula what an organization can, follow and see the kind of financial outcomes? So over to Dr. Puri.
Thank you, Joy. First of all, I'd like to acknowledge PD Hinduja Hospital and the quality that they have provided over so many years to the citizens of Bombay. And my hat is always doffed whenever I pass through the portals of that institution or had the opportunity of doing so. So you're doing a wonderful job. And Joy, I've known you for so many years in the healthcare management field, and you have your CEO, Gautam Khanna, who's far more conversant with the financial part, as a colleague at FICCI, and I've learned so much from him. But coming back to the question that you asked, if you were to look at the cost of quality, it's very easy to think of the cost from the perspective of financial returns that accrue out of good quality. Nobody seems to factor in the second part of the equation, which is the cost that the organization or the business house suffers because of poor quality. It is a well-known fact, particularly in the healthcare sector, that if you have one discontented or poor outcome patient, it translates actually into a loss of 25 more patients who would come. Because one person usually talks to 5, and those 5 talk to 5 each. So therefore, if you look at the simple equation of quality, what is the cost of quality? It is the cost of good quality plus the cost of poor quality. Now, the second part, as I said, is invariably ignored. Now, whenever you and I buy any product or any service, we, particularly for products, we are looking for what we call AMC. You are not going to buy a robotic machine or even an air conditioner for home use without getting an AMC. A lift that is installed in your institution will always come with an AMC. What is an AMC? AMC is prevention of that loss that might accrue. So from the perspective of financial returns being quantified, there are innumerable articles available in the journals, but I'm not going to refer to them because it's difficult to compare one organization with another because of size, because of the investment that may have been or may not have been made there, and from the countries, most of which that we are referring to come from countries abroad. And therefore, I'm speaking more from the perspective of experience in the Indian context. And I would say that the usual formulae that are followed to calculate the cost of quality, if you factor in the loss that is likely to occur because of poor quality, you're more likely to get a true picture. But to put it in a quantified manner, it's very difficult. Quality always lies like beauty in the eyes of the beholder, isn't it? But in healthcare sector, to calculate the exact cost requires not just formalization, but also the what is traditionally theoretically taught in quality as the 4 aspects of cost of quality. The first is the measurement of quality. The second is the prevention cost. The third is the internal failure costs. For example, those costs which you will not allow the patient to even know, but will take preemptive measure before the patient is exposed to that. For example, a robotic arm failing to function when you put the switch on, or whenever your laparoscopic light doesn't come on, etc., because you've done that preemptive checkup. And lastly is the external failure cost, which automatically accrue when the patient has actually experienced a bad quality and will complain to you. So ultimately, if you want me to go into the theoretical part of these things, there are dichotomous results which are available in the review of literature. Some have quantified the returns, but others haven't. And very few articles actually mention this as a calculated figure, which is available in Indian conditions, which you can compare apple to apple. So if you can't compare, for example, a super specialty quaternary care hospital with, let's say, an eye hospital, the cost, the quality, etc., incurred in both the aspects of prevention as well as out of a poor quality outcome will be very, very different. So I'll stop here, and I'm going to listen with a lot of consideration for what Mr. Gautam Khanna has to say, because I believe that he has a far better financial head than I do. Thank you.
Thank you, and you have given the inputs in terms of that how the non-conformance can cost and how a quality non-conformance can take away the patients, the customer from a hospital, and we agree with that. Now I move on to Mr. Khanna. In Indian scenario, if you see that cost of quality or the impact of non-conformance comes much later. If we look at Western world, especially the US and certain part of Europe, where the insurance company, they do reimbursement and they look at the quality outcome, and then the reimbursement varies from provider to provider in a significant way. But that is not the culture in India as of now. So the question to you, keeping that in mind, that do you think there is always a cost of quality, and do you think that cost what we incur to meet the quality requirement gives the benefit, or it becomes more than the cost, the benefit what we get, and what we should do in the Indian healthcare providers environment?
So Joy, thank you for asking, and Dr. Puri, comments always nice and welcome. So wonderful to hear from you, sir, and your kind understanding of the subject. Hats off to you. So to answer a few things on this, so let me just try and say that when we talk about the financial outcomes, so the issue is about financial outcomes. So let's look at it in two ways. That financial outcomes are, there is a plus and there is a minus. So the cost is something which we are talking about is the minus of the revenues. So what I'm saying is that if you don't have quality and you have errors, you have service issues, so there will be a loss of revenue, and which you mentioned just now as cost of quality, cost of poor quality. And that is that is sometimes known, sometimes not known. And I think the way to do this is that we don't want to go to that route and say, let us try and have a poor quality and then see what is the cost. We don't have to do that. We just know it. All we have to do is we have to measure the metrics of quality and see if those parameters are met. And then maybe we can do an analysis inside without actually going through the errors, is that if this metric was ORI by so many %, what would have happened? And that is one way to do that. But sometimes it's not necessary to do that. It's okay to analyze the metrics related to quality, and if there is an improvement, you do that. So that is the cost of quality. The other side of quality, which is from the financial outcome, is the plus side. So everyone talks about the plus, the cost of quality. I want to say one way of judging quality, whether it has benefit or not, is whether the patient perceives you to have quality. And you will know from the patient feedback, of course, you will know what is the feedback and you will know what they want. But also, is there a premium which they are willing to pay for your services? It's like the reputation of your brand, the reputation of the hospital. If there are two equivalent hospitals in the same city, and one hospital commands a slight premium over the other, there is perceived quality is better in that hospital. And so there are two ways. So one way is when we say quality, of course, we avoid the costs by measuring metrics. But second is we enhance the revenue by getting a little premium. And if some hospitals are not able to get the premium versus the other competitors, then this is something to be thought of, that maybe what we are saying quality is everyone has the quality. So maybe our quality is the same as somebody else. And there is no perceived difference between the two hospitals, and the patients don't think one is better than the other. Because if they think one is better than the other, they will pay you a premium. So to look at it financially, we need to look at both plus and minus side of it. And then, when you do the metrics and you look at efficiencies, you know that efficiency goes up, your service levels go up, and there are less errors. So there is obviously a financial benefit of that. I mean, you may or may not measure it, but it is there. Let me just stop at that, Joy, for your next.
So in continuation to that, like as you mentioned, the point that a patient should find and should be ready to pay more when there is a better quality which is perceived by them. Now question arises that how a hospital will represent to the patient care community about their quality outcomes, and how it will be communicated that if you go to such and such hospital, then you get better quality. Because today we know that across the country we have few hospitals which are NABH accredited. There is a stamp of accreditation, but there are not many, and probably everyone is projecting themselves as a best healthcare quality service provider. So question is, how does someone portray and get a perception in the patient's mind about their better quality?
So Joy, I think the best ambassador of quality is the existing patients. The experience which the patients get in the hospital after the treatment. The word they say, Dr. Puri nicely said that one person affects 25 other people when it is negative, but it's sometimes true of positive also, so that they affect positive also. So if there is a way to link that, let me say that you have people who are talking positively about you, the patients who leave, they are the ones who will generate your brand. And that is what is important. Second thing is, of course, the processes have to be nice. It should be a seamless, efficient processes in the hospital, which anybody will know. So sometimes, and the patient, of course, will know, but also very important that the patient's relatives also see it. Because this is my request to the hospital providers to understand that the patient relatives are a key component in perceiving the quality of the hospital. How we treat them, what they see of the quality is also which makes a difference. And when they go back, of course, this one is assuming that they have to have a good clinical outcome. So that I'm not disputing at all. But I'm saying after a good clinical outcome, the experience they have in the hospital of the processes, of the efficiencies, and the experience they've had in dealing with the staff, whether it is a security guy, whether it's a doctor, whether it's a manager, whether it's a director, the experience of the relatives and the patient conveys the quality. And over a period of time, this gets built up. And sometimes we think that, how will people know? People just know that they know that if you go to a certain hospital, you will, staff will be empathetic. Staff will will take care of you as a member of the family, which our hospital has the reputation of, that, they take care of you as a family member. So these things, along with the processes at the back end and managing metrics with the empathy of the patient and the behavior, is what the relatives perceive. It is like, it's a standard thing in quality also, and in psychology also, that you have, the behavior is what is visible. It's like the tip of the iceberg. The 95% or 90% of that iceberg is hidden behind, which is below the behavior. It is related to the values, the processes, the training, and the way, the compassion they have. And that translates into behavior. And that's what I think it is. Over to you, John.
Thank you very much. And we understand that the behavior, the way processes are, and your patients who are already experienced the services, they are going to be the best brand ambassador to carry forward the message of quality and ensuring and giving that kind of confidence to the patients that what they can expect when they visit a hospital. So I move on to Dr. Puri once again. And to Dr. Puri, my question is going to be that from an international perspective, we have seen the involvement of NABH accreditation in India for last 15-16 years. But if we look at it from international market, international arena, what is your opinion whether quality and accreditation, they really deliver better financial outcomes?
That's a very good question and a tough one to answer. Joy, the fundamental point is that a lot of people confuse accreditation with quality. Accreditation is a quality tool, just as Six Sigma is, just as TQM is, just as Kaizen is. So from the perspective of accreditation, you are giving a degree of conformity to quality standards. And there is a third party which is ensuring that what you say is actually being delivered. This is opposed to, let's say, when you get an ISO certification in which you set the standards. Let me give an example. If you have applied for an ISO, your organization may say that my knee replacement patient will go home after 1 month, and he goes home after 1 month, you will get ISO certification. But you and I know that the patient should actually go home within 48 hours. So it's the same with blood sugar results. So the reason is because in ISO, you set the standards and they just come and check whether you are following the standards that you have set. In accreditation, which is an WHO approved system of a quality tool, what you're saying is that somebody else has set the standards, somebody else comes to check whether you are fulfilling those standards, and there is a periodic process of revision that you will have to undergo. So therefore, it gives you greater credence in the eyes of not just the patient, but also the people who are working in that accredited hospital. So confusing accreditation with good quality is not the right way to look at it. Accreditation is quality because quality essentially means conformity to requirements. And somebody else is confirming that you conform to requirements, gives you a higher peg to hang your coat on. So let's not confuse the two. Now, given the fact that NABH is relatively new, the first hospitals got accredited in 2005, 6 only. The fact that Indian quality standards set by NABH have been reviewed periodically by ISQA, which is the International Society for Quality Accreditation. It used to be headquartered out of Dublin. Now it's in Lausanne, in Switzerland. The fact of the matter is that ISQA has not just certified our standards, but they have also certified the accreditation that we give to the institution. Therefore, it holds to be on the equal pedestal, shall we say, of, let's say, the Australian system or the JCHO, etc. So from the perspective of the quality, I'm just adding to something that Gautam has already mentioned. The trouble with the healthcare is that in healthcare, you have two distinct elements combining to give the patient and the patient's relative an experience. One is the medical piece of it, or the hospital piece, and the other is the hotel piece. So it's easier to judge the hotel piece because there are set standards that you conform to. But whenever a patient comes, let's say, to get an appendix removed from a hospital, he just takes it for granted that you are going to give him good quality, that the surgeon who's going to operate knows how to remove my appendix, the anesthetist knows how to put me under, and that your post-operative team will look after me. Where the difference in quality comes, particularly in private sector, is where you start judging from how good was the linen, did the nurse come after 30 seconds or after 1.5 hours when I rang the bell, etc., etc. So you start judging on service parameters. So this is a very peculiar industry where you're judged on two very dichotomous kind of situations. One which you take for granted, and you want that my patient has come to the hospital, you know how to look after him, and he has to get better, he has to live and go back home. But you also want, and probably the patient's relatives, as Gautam rightly pointed out, when you talk of patients, you never talk of patient alone in a hospital. The relative in India has to be factored in. So if the relative of the patient who's in ICU at 1 a.m. can't get some place to put his feet up or can't get a cup of coffee, you have delivered poor service as far as he is concerned. And like that old saying in Hindi, it used to be, when a patient comes to the emergency of a hospital, Dr. Bhagwan hota hai. When he goes to the ward, Dr. Insan hota hai. Aur jab bill aata hai, to Dr. Shaitan hota hai. So in 3 days, the reputational capital of an institution and the doctor changes because you get a bill. But when we talk of quality, we tend to forget that it is this difference that makes India, even the rural India, pick a very difficult decision of even selling their jewelry, mortgaging their land to come to a private hospital. Because there is this impression that the quality in private hospitals is better than the one in government hospitals. We all know that fundamentally quality is a simple Donabedian theory of structure plus process is equal to outcome. But in reality, at least in the medical world, in my 58 years of medical education to now, I've rarely seen a classic case. So you don't find everything where you're supposed to find. There are always individual variations. And whenever individual variations occur, the processes need to be redefined sometimes at the moment. And this produces at times outcomes which may not be good. The trouble is that that should not stop us from measuring outcomes. Where the problems come from is we tend to take quality and we continue to think that it'll just occur because my doctor is qualified, my nurse is well trained, and this will happen. So I'm sorry I'm giving a somewhat dilated answer, but a practical one from the perspective of the young quality professionals who are out there, that what Mr. Khanna is saying is absolutely right from the perspective of patient expectations being met. But your question about NABH ensuring that you will get financial returns cannot be answered by an accrediting body. Or what you're doing is that you're ensuring that those 10 chapters that your hospital is following, 5 of them are medical and 5 of them non-medical. They merge into producing in giving an impression to the public that if you come to an accredited hospital, you're more likely to get better, and that the processes of these hospitals have been vetted to be good. It's like telling a woman a lady who's going to buy jewelry, that you look for a hallmark, or a farmer being told to look for the ag mark for the fertilizer. So it's the same. It's a kind of an assurance seal that this hospital follows processes and has the necessary structure to give you good quality. But can it ensure that your patient will not die and that your patient will get away without getting an infection? Sorry, that's not possible.
Thank you very much for this, elaborated response, and I'm sure the audience who are attending today, they are going to take this message. And one of your points, what you have mentioned initially at the beginning of the answer about accreditation and quality, and you have told not to compare this between these two. It is like a process to get the kind of stamp to say that you are following certain thing, and you gave the example ISO of how you define your process and how do you match that and you get the certification. It is very nicely given comparison. So now, as many of them will be looking forward to hear from you, so can you tell Dr. Puri, in terms of quality, if someone wants to ensure in their hospital, in their organization, you have any framework, any advice that what they should follow, even if accreditation is not there? What should be the roadmap, how it can be taken forward?
Well, that's a tall order to ask, Joy, but I'll try to in brief mention. As I said, that the building blocks for quality, and quality came to the healthcare world from the manufacturing world and from the service community, just as management came through from the armed forces, let's say from the Second World War, how supply chains were maintained. So there is always a historical perspective, but it tells us two things very clearly. One is that your structures should be sound. For example, let's take the example of fire. So have you taken adequate measures to see that you have sufficient fire protection tools, that your building is certified by the fire department, so evacuation is easy? You in Bombay have experienced it during the COVID times. Everywhere in the country, we have noticed that there have been loss of life. Calcutta, that major fire in a major hospital happened. So your structures have to be sound. Now, when you say structures, it does not mean structures which are physical. Structure also means, have you looked at the personnel that you employed? Now, I find it quite galling that you have in ICU people who are unqualified. Certain hospitals are running ICUs, but they don't have even an MBBS doctor manning it. I don't understand how that is good practice of medicine or good quality. Forget about good quality. To me, it's illegal. But that's a part of process. Are you checking the qualifications of the doctor who says that I have 20 years experience of doing this, that? So my point is that's also a part of structure. So when your structures are sound, your processes will work on those structures. After all, you require a framework. In Gotham, we have an engineer from IIT. So I mean, I hope he doesn't mind my saying this, but my point is engineering skills are one part on which you can build the medical skills. But if you don't have a building, you can't have a hospital. And if that building does not conform to what the hospital's requirements are, or the doctors or nurses' requirements are, your structure is defective. On that, you build your processes. Now, those processes will per necessity, have to be those which take into cognizance the requirement of a patient or patient's relatives from the point of view of safety. That's why almost all over the world, nobody is calling these departments and departments of quality. We are calling them departments of quality and safety, because they need to be. Healthcare is a very unsafe profession, as we all know, and it's not. Healthcare isn't even an exact science. The main thing is that you need to reduce the errors to that is may not be zero defect, but very nearly what zero defect is, like Philip Crosby said. But my issue here is that majority of the hospitals who start on the journey can be aided and abetted by structures like NABH early registration, which you have a full accreditation and you have an early accreditation, or which you can get into. That will help you climb that will help you climb the ladder in a certain manner. The trouble comes that the bigger hospitals, and more likely the private hospitals, get into this because of the reputational capital loss fear. But very few government hospitals, including, let's say, the All India Institute of Medical Science, which recently has now applied for early registration, aren't actually accredited. So accreditation, I think, should be a minimum. Several countries in the world have made it mandatory. And I just wonder at times if in a country like India, where there is so much of unregulated healthcare, whether it should be made mandatory. There are pros and cons of it, and perhaps you will discuss it in some of your conferences. So I hope I've at least partially answered your question. I'm sorry if I'm being a little political in not being very specific and slightly vague.
No, I completely understand, and definitely we'll take it up in some other session. And as we are continuing to discuss about this, translating quality outcomes to financial outcome, I want to share with the audience here a very favorite case study of mine, which I happened to read close to 10, 11 years back from Harvard Business School case study, their details from their library, that Virginia Mason Hospital in US. So little bit background, and with that I'll move on to Mr. Khanna. The story says that somewhere around beginning of 2000, the hospital was incurring major loss, and they're almost at the verge of closing down their hospital. And they didn't have a very good governance system, but more than governance system, they were finding it very difficult to maintain them meaningful and useful for the community. And as a result of that, in the competitive market scenario, there was a huge rejection from their patient base, from the community, to visit the hospital and take further treatment. So at that juncture, they took a lot of, they made a lot of efforts to come back to the action. And one thing happened, it was incidental as well as accidental, where they came across a senior management person from Japanese automobile industry, where they happened to learn from the production system, Toyota production system. And over a period of 3 to 4 years, they completely got involved into practices like Kaizen, 5S, and Lean, and all this. And that completely turned around that hospital into a profitable hospital. Their financial figures become much better, and today they enjoy a very good reputation. So my purpose of saying this, that there are few examples where we have seen this quality improvement, quality processes has brought significant financial outcomes. So with this, I move on to Mr. Khanna. that do you think, and this question is in respect to Indian scenario, that healthcare organizations find it difficult to express quality outcome and validate and convert them into financial outcomes, and how can we move ahead from this?
So I think we heard very nice example from you and what Dr. Puri mentioned. So it's clear that there is a impact of quality on the financial outcome. We saw that. But I have to say from what just a comment on what Dr. Puri mentioned. He talked about NABH, entry level, and so on. I think the hospitals need to know that one level of quality, if you give after a year or two or whatever the time frame, it becomes a basic minimum expectation of the patients. So it's like a hygiene factor. Then when it's a hygiene factor, you don't get any benefit for it. But if you don't have it, you have a penalty. So I think the journey to improve quality year on year and move to the next level of certification and accreditation is important for all hospitals. So if some hospital thinks that I have NABH certification done 3 years ago, and I should get some financial returns, unlikely, because the patients have assumed that this is a minimum. Second thing, which I want to just give a little bit of a challenge. NABH inspection and audit in financial terms is like a balance sheet, which is done at a point in time. So you pay the financial accounts on 31st March, same way you do your audit and so on. Now, at that point in time, you've checked the processes, you've done everything. But what is important to check in a quality hospital is to, in the similar things, to check the P&L on an ongoing basis. P&L is monthly review of all metrics. So if you don't review the metrics on a monthly basis, you will have a problem. So I think what you mentioned, that what can hospitals do? How can they translate this to the patients? If they keep improving metrics on a month-to-month basis or whatever period they choose for, they will have the patients will start perceiving quality. And I have mentioned this perceived quality a couple of times because it is different from the quality you mentioned and quality what Dr. Puri mentioned and what everybody mentions. Because quality is what is internal to us, what we are doing, the structure, the processes, the training, and that is what it is. What the patient and the patient relatives see, they don't see quality. They see perceived quality, what they think as quality. So I think the mismatch between perceived quality and quality is the problem. And if we start continuing on the journey to understand that I may have the best people, I may have the best structure, I may have the best processes, but if the patient is not able to see the benefit of that, or is not able to perceive that there is some quality in it, it's of no use. So I think that is important to understand. So there is a little bit of art in the quality. So the science of quality with metrics, with processes and so on, needs to be balanced with a little bit of an art of behavior and perceived quality and so on. The other important thing I think which the hospitals should do is very seriously I know many hospitals do this, is do the fault analysis or the whatever is the error analysis, but don't leave it by fixing the error today. Go to the root cause, and I know everybody talks about root cause because it's written in all books and everybody is trained to talk about it, but I think in practice, go to the root cause, that same mistake should not happen again. And I say is that we all are learning. So we all make mistakes in our journey. We try new things, we learn, but you can't make the same mistake again. Same mistake again, that means you have not learned from it. So that's my suggestion to the hospitals, that go to whatever is the error, whatever has been the fault, go and fix the root cause, and then make that level of quality as your hygiene, and then move to the next level. I've seen Dr. Kocher joining, so he'll be very happy when I'm saying you need to continue to move to the next level of accreditation in NABH as the years go by. Over to you, Joy.
Just to add, Joy, if you permit me, I think Gautam is absolutely right. I would just mention that if quality is handled well by addressing the main issue and finding the root cause, and then not making sure that it doesn't happen. NABH actually, when it comes for a review after 3 years, does look at CQI, that is continuous quality improvement. So your standards need to be shown to show an improvement, which I think is a good thing. That's a requirement. But the important point, I think Gautam has rightly pointed out, is what I refer to as expectation from patient about the medical quality being good. And that's why we've come. The service quality is where I think perception is even more important. But if you use quality well, it also becomes a very good communication tool. You can crow to the world about the good outcomes that you have, like India does when it comes to cost, let's say for a cardiac surgery. But it also simultaneously mentions that our cardiac results are 99%. So unless and until your outcome-based quality control measures are demonstrated and talked about, that perception will not change. Therefore, you can use every institution that is having good quality, not only as Gautam suggests, you should do work on this to change the perception by talking about it and using it as a communication tool to mention that these are the good results, or these are the non-viable kind of things that were happening, which we have taken care of. Sometimes transparency is sacrificed at the altar of financial non-disclosure. But in quality, I think the greater the exposure and acceptance, the better it is, particularly internally.
Thank you, Dr. Puri. And as Mr. Khanna said, couple of points I just repeat here that he mentioned about we need to continuously improve our performance. So in NABH, we have continuous quality indicators, and we really need to focus on that and see that the activities and initiatives should not be around only during the accreditation inspection, but it should be throughout the period. And the second thing, the perceived quality, and that perceived quality needs to be really taken up seriously by the providers to ensure that how you can improve that time to time. There may not be any indicators as such, except maybe the patient satisfaction index. But in those areas, we also need to work to give them a complete flavor of better quality healthcare delivery from our hospitals. So with this, I move on, and I'm pleased to share with the participants that Dr. Atul Kochar, he has joined the CEO of NABH. I'm sorry, he was in another forum and he told me that before. Probably I have kept him away from his lunch, but it is nice of him to join in this session. So just to introduce him, he was awarded the University Gold Medal for excellence in field of dermatology, venerology, and leprology. An active practicing clinician with a passion for quality in healthcare, a principal assessor with NABH. He was since December 2019, he has taken charge as the CEO of NABH, and his interest in quality and propagating the message of quality is really admirable. He takes a lot of interest in terms of promoting patient safety, quality, and taking best healthcare practices to the last in the line. And this is mission of his life. So welcome, Dr. Kochar. So I'm going to ask you the question. Are you there online, Dr. Kochar?
Yeah, Joy, thank you so much for this privilege. And at the outset, sincere apologies for the late entry as I was held back by the conflicting assignment. And, uh, and what a great privilege it is for me to sharing the dais with one of the founding fathers of NABH, Dr. Puri sir. And it's always a pleasure to listen to Mr. Gautam Khanna also. Thank you.
Thank you. So before you have joined, there are a lot of deliberations on this quality, financial outcomes, as well as quality accreditation and all this. So I'll come straight to the point that as a head of one of the healthcare accreditation body in the India, one means the topmost, I think we consider at the apex one, that do you think hospitals have benefited financially post accreditation? We know there are CGHAs and other schemes which give certain additional reimbursement for the NABH hospital, but I'm not considering that. But do you think really this accreditation system in this country has given a different lift for the healthcare providers, which has helped them to get better, financial benefit?
Definitely, and unhesitatingly, I would say, if we were to look at the larger definition of the benefits, financial or otherwise, I think the entire concept of accreditation, I mean, it's a proven concept, worldwide has given a lift to the entire system of patient outcome, patient care, and patient safety also. With having said that, let me go back a little to the background and quote some data figures also. That despite the entire, if we were to look at the entire history of medicine and entire history of patient care, the patient safety, the accreditation concept, the quality, they are all not very old concepts. If we could take the Joint Commission as the founding stone of the linchpin of the entire accreditation framework, I think it's about 70, 72, 73 odd year old body. The American accreditation system came about in is about 43-year old body, and our own NABH is we are into the 18th year of operations. So during that time, despite all the workings, the standard and everything, um, I think the adverse reactions are still one of the top 10 leading causes of causing death and disability um, in the top 10 list. If we were to talk about even the most developed nations like US, 1 in 10 patient is harmed even today, um, arising out of adverse decisions on an inpatient procedures. For OPD level, this figure rises even starkly to up to 4% of 40% of patients. So which is a huge figure. And what to talk about low and middle income countries where in the last published data, 134 adverse decisions were adverse reactions happened and 2.6 million deaths and disabilities happened. And even if we were to count of the quality of life, we focus on that, then the disability adjusted life score, the daily, that itself is a stark reality of where we are. Now, coming to the financial, your proper question, if we could end up preventing even one death by certification or accreditation, and I'm sure that figure climbs very rapidly, that preventive angle, then the entire benefit cycle of accreditation starts to make lots of sense. In fact, much more sense than the tangible 10% or 15% upscale over the published IRDA rates. I think that itself is a huge figure translating for multi-speciality hospitals. But the non-tangible benefits by themselves, the outcomes which improve year on year for old standing hospitals like Hinduja Hospital, which is, I think, one of the flag bearers of accreditation and patient safety. So to talk about your own hospital, you must have seen that how over the years, these simple steps of coming together, I mean, when a hospital or the incentive are the certificate itself, just to get that thing because it is there and then get that financial incentive initial, which is there. But over the next few years, that outcome starts to follow, the system starts to fall in place, the processes are but better defined, and suddenly the patient care angle, the patient safety angle starts to make absolute sense, and the patients are happier lot. And as Dr. Puri sir said, that this quality can suddenly be showcased as part of the communication network also. And today, in a world where there's huge amount of trust deficit between the doctor, the patient caregivers, and the patient community, where we are living amidst a sea of litigation, potential litigants. Every patient is a potential litigant. The quality, the financial benefits start to make lots of sense. So if we look at the whole picture, I think it's a very sensible financial idea to go in for accreditation. I mean, there are n number of use cases which we can demonstrate, and huge number of data which is already there, which will underline and underscore the fact that patient safety and is a good talking point, good reference point, and accreditation framework is absolutely big. Your wonderful question.
Thank you very much, Dr. Kochar. And you have come directly to the point in terms of how disability adjusted life years, mortality, and other kind of scenarios can be prevented, can be stopped. And that indirectly gives the financial benefit outcome not only to the hospital, also for the patients. And we know very well that in several cases, redoing of surgery or readmission, how that can indirectly costs a lot, and that becomes not a very good financial scenario, because sometimes this kind of scenarios doesn't make any sense for the providers to come into the situation. The revenue what they get, that may not be a very useful, because the cost or the reputation can become much higher for that. So before I move on to Dr. Puri with the next question, I want to request the other audience, they can post the questions if they have, and we'll be taking up some of the questions at the end of the session. So I move on to Dr. Puri with the next point. And as you are a person who was in teaching, and from you, many of us have learned many of this, quality administration and things like that, that do you think that healthcare providers should organize, arrange some sorts of training, especially for the doctors, because in many occasions they are not in the stream to understand this, and they look at it in a little different way. The nurses, the hospital administrators, and even the quality managers, some sorts of training, especially related to finance and other areas, to get a better horizon of knowledge to handle this subject. And then automatically what will happen, people will drive quality, people will work on quality to see gain for all stakeholders. So over to Dr. Puri.
Well, absolutely. Joy, that's a wonderful question and a very practical one. I think it's a two-way street. It's very common for doctors to blame everything on the administrators. And administrators think that doctors are like kids. They want the latest toy without understanding why they want it for, or the quality manager who keeps asking that I want this, etc. So these are like, I feel these are like two railway lines who, whenever they cross, there is parking. But as long as they make the train reach the destination, that's fine. So it's not just that the administrator wants to, should have a look at what quality managers actually do and what kind of systems operate, because most of the managers who come from a non-medical background have never been to the OT or the cath lab themselves. So they should definitely go there. And all doctors, particularly who are working in corporate institutions and even in government institutions, should be definitely exposed to the modicum, a module of finance. I'll tell you my own case just to illustrate a point. Many years ago, when I somewhat reluctantly joined a corporate healthcare chain, some 22 years ago, I didn't understand the spellings of finance. I knew nothing because I'd come from a background which was completely different, where you're not supposed to know finance. And in medicine, nobody teaches you finance. The first board meeting that I attended, this is not an apocryphal story. This has actually happened to me. I was sitting, I was invited into the board meeting. There were 7 of us, and 6 of them were non-doctors. And I was the only doctor, and they were talking about EBITDA. I had never heard the term EBITDA. So I turned around to the guy sitting next to me, who happened to be the chief of HR. And I said, "What is EBITDA?" So the guy burst out laughing in the board meeting, and he turned to the chairman and said, "Sir, he's asking what is EBITDA." So I was a little sheepish because, I thought I was asking a very genuine question. I didn't know what is EBITDA, and I'm asking what is EBITDA. And then they explained to me what EBITDA is, but everybody was sniggering. So I felt a little offended. And I said, "Okay, this is a healthcare company. Do you know what is AMI stand for? Or PL and PR?" So they said, "No." So I said, "Then how come you are in healthcare?" AMI is acute myocardial infarction, and PL and PR are perception of light and perception of rays in ophthalmology, and PR is per rectal examination. And you don't know, then why are you saying that I don't know EBITDA, therefore you're sniggering? My point is, both have their own viewpoints, both have their positives, but they must learn from each other for the common good of not just the organization that they serve, but for the common good of the healthcare. So that's a very important aspect that you've touched upon. In fact, many years ago, NABH had approached the Medical Council of India requesting that 4 things they should include as probably optional subjects to be taught to undergraduates in health in MBBS course. One was quality, the other was patient safety, the third was communication, and the fourth was finance. Because 70% of the graduates who get out of medical colleges do not join a government organization. They either start their own clinics or go into private institutions where some modicum of financial knowledge is required. And I don't want anybody to be in the sort of situation I was when I didn't know what is EBITDA. Now, of course, it's become EBITAC, but today you understand what is ALOS. But you ask a medical college guy, what is an ALOS? He won't understand. And the vice versa part is also equally true, which is why in the leadership courses that are conducted by organizations, it should be important for the non-medical people also to be made to see what happens in emergency, what happens in operation theaters, what happens in ICUs. Because unless and until you see that, understanding will never come through any kind of a lecture or a talk. So I support it totally that finance should be taught to medical guys. And if not anything, it will probably make their life easier with their wives or spouses.
So, I'm sure that this was a very important point, that how do we keep our healthcare workers, how do we keep our healthcare providers team updated and skilled to manage different kind of environment and scenario to ensure best and effective healthcare delivery. I'll move on to Dr. Kochar once again, and a very specific question. we maintain certain mandatory indicator, we maintain certain, performance indicators. Can you suggest that, is there any specific performance indicator that the hospital can monitor in addition to the NABH indicators to gain, evaluate, and align financial performance, financial gains, and compare that with the quality, delivering quality care? So if you can indicate, so it will be helpful for the audience to follow that in future and keep them updated. So over to Dr. Kochar. Dr. Kochar, can you hear us? I think he is not able to join. So I'll move on to Mr. Khanna. I'm going to ask a question that as a CEO of Hinduja Hospital, can you suggest few prescriptions or some, kind of tips to the hospital that how can they follow the quality pathways to garner better financial gains?
So I think one of the important things for all hospitals to know is that the quality for the hospital is not the job of the quality manager. Yes, quality manager is there to further documentation and to help in the processes and so on. But the adherence and commitment to quality will have to come from the senior management themselves. So that's an important part. If the senior management doesn't think about quality, it's not going to happen. That's one. Second thing is quality should be visible at the lowest level. So irrespective of what we do at the structure, the processes in between, and we monitor, we have metrics and we show the dashboards. But if the person on the ground meeting the patients, interacting with the patient and the patient's relative is not able to deliver quality in terms of whatever they're supposed to do, whether it is a clinical discussion, whether it is a service level discussion, as Dr. Puri put, it's not going to happen. So that's one aspect. So you have to periodically check if that's happening. The other thing I think I was listening to Dr. Puri and Dr. Kochar when they were talking about quality. I think one thing which we are talking about is that quality, why doctors are not there. I don't think that is true. Of course, they need to be given exposure to quality, which is true. But the MBBS course is designed to make a better doctor, and many doctors may not work in hospitals. So they might work in a in their own setup, or private clinics, or nursing home, or whatever. So I think the issue about letting them learn about quality, about finance, I think learning about finance is a life skill they need to have, but not essential. I think many of the doctors are probably much better in terms of financial planning than some of us. And in terms of quality, definitely they should be exposed, because once they leave the course and they go on to practice, they are focused only on their professional excellence about delivering good clinical outcome. And they need to also understand, as the complexity is growing, as the hospital size grows, as the number of patients grows, or their practice grows, the higher level of complexity and scale will need them to monitor quality metrics. Because unless they have a system to find out what the metrics are, then monitor and then improve, it is going to go downhill. So I think that exposure to quality and exposure to finance is okay, but exposure to quality is more important. And the other thing is, within the hospital, it is important to keep sharing with the clinical community. And I like Dr. Puri's idea that the non-clinical people need to also know what do the clinicians go through in emergency and so on. So there needs to be a system, whether even if it is, just visiting them, talking to them, or attending their conferences, or maybe some of those. But I think it is a journey where there is no clear answer that this is the prescription, you do these three things, this is what's going to happen. But you have to try all, and you have to move in this journey as time goes by. Thank you. Over to you, Joy.
Thank you very much. And Dr. Kochar is back. And actually, I mentioned the question before when you got disconnected. So very briefly, I'll ask you that do you recommend any specific performance indicator which is arising out of NABH accreditation, or maybe beyond that, what a hospital can monitor to evaluate and align financial gain with quality? So over to Dr. Kochar.
Yeah, thank you, Joy. I think it's been a session of Murphy's Law for me, entering and leaving and then coming back. But thank you so much for your patience and sincere apologies. So, as everyone is aware, actually, the entire sum of accreditation, the NABH grant, is based on the concept of accreditation itself is based on the monitoring of certain key performance indicators. In the fourth edition, we had about 72. We trimmed down to come as a part of our commitment to ease of doing business to 32 core indicators. And each of these 32 core indicators has a financial implication. And this implication, whether tangible or non-tangible, can give the administrators, the managers, a wonderful look into their own systems. Because NABS system being what they are purely generic. We leave to the hospital about what scope they decide to have, what services they wish to provide, and what care they wish to take it upon themselves to give to their patients. So all these 32 indicators, leave aside the ROMM and the other, I mean, they're very crystal clear. They're in plain English actually. So they go a long way and translate into financial extrapolation for all the administrators as well as the clinicians. And I totally agree with Dr. Puri sir and Mr. Gautam also when he says that this is a patient safety, patient care, financial prudence. They also have, it's everybody's job. It has to be all hands on the deck. And we all have to work together in a collaborative manner to give our best. And so each of us must be aware about what the other one goes through. And it's not, we cannot expect somebody to work in silos. The clinicians work really hard to give life to the patient, the administrators, and today administrators like Mr. Khanna or Joy, they realize that thing also. And I think with the coming generation of senior people, because every management institute is having elaborate few precious hour on quality. Every quality manager has to go through a quality, and with some luck we'll be able to convince our councils, National Medical Council, to have but the prospects we are speaking about it, and our policymakers have taken note. The promise of an increased GDP, and I think the coming future is very, very optimistic for all of us. Thank you.
Sure, and I'll just extend extend the point that, when I was part of the accreditation committee and we used to sit for the accreditation committee meeting for granting accreditation, we used to hear from the secretariat that a lot of hospitals are asking and following up with their accreditation, whether they have got it, and because they had a lot of expectations and expectations on the reimbursement from some of the state schemes, centralized scheme, and they used to follow up. So do you think these Indian hospitals, though it is a great journey for last 16, 17 years, that Indian hospitals are going for accreditation to gain financial benefit? There may be few hospitals who are doing it because of their love, their commitment towards quality. But is it most of the hospitals are going for that?
No, absolutely, absolutely. So as I mentioned earlier, when the first time a hospital, any hospital, big or small, decides to partner with NABH, it is for the certificate, for the linked incentives, for the financial benefits. That's a, I mean, everybody knows actually. So that is the thing actually. But once they start to implement them, slow by slow, some fast, some maybe a little later, they realize that what a great opportunity NABH has provided them to make a difference to their own protocols, to help towards patient safety, to improve the outcomes of their patients, and not only patients, to also NABH strengthens their policies and procedures for upkeep of their facility, their systems, and their staff, not only the ministerial staff, but also of the doctors. So NABH or any accreditation system which is tested and validated, just like NABH, is designed to improve the entire mini cosmos, which is the hospital actually. It helps. And that realization, once it sets in, the key leadership takes note, and they self-propel and they become the brand ambassadors of NABH. So first thing is always the financial incentive, and going forward, slow by slow, it hits you actually. Every good leader today supports NABH. I mean, you two are sterling examples. Dr. Puri sir himself, I mean, he may have a conflict because despite being a very senior most administrator to large groups, he was also the founder of NABH. So one of the founders. So he may have a conflict, but many top leadership today is extremely supportive of accreditation system, and not only for that 15%, which itself is a large number. So going forward, the excellence mechanism, the patient safety, I think that culture has to be sustained. And today NAB stands tall on leaders like you. So thank you so much for that question also, and your support, your always explicit support to the accreditation also.
Thank you very much. And we have got a very clear message in terms of following those 32 indicators. And if you do things at the right time, then things definitely will give a desired result. So with this, I'm concluding this, the panel, and I am having few questions in the question answer box, and I'm going to take up 2 or 3 of those before I conclude this session. The first question has come, probably this is for Dr. Puri, where it says that is comparing healthcare to airline industry, is it fair? The question is from Anjali Arun.
Well, that's a very old question, which has been addressed by far better qualified people than I have. From the perspective of, there are certain similarities. First of all, let's talk about what is similar. One is the technical part, which is, let's say, the medical part in healthcare. And then there is the service part. So they're the technical come service or medical come service industry, they kind of merge. The second is the use of technology, which leads to better outcomes. And the third is the process. I think airline, a lot of, as I said, from the times of Juran and Deming, we have learned about quality journey from industry. And aviation industry is amongst the safest in the world as compared to healthcare industry, which is the most unsafe industry, if you were to count it as an industry. There is a lot of lesson that healthcare needs to learn from aviation industry. And the most important part of that is the process. So the checklists that the aviation industry goes through, every pilot, I'm told, he or she, when they sit in the cockpit and talk to the co-pilot, there are 45 or 47 points that they recite. And that's nothing else what Atul Gawande has brought out into the WHO checklist of patient safety. So it's not fair to compare the two, but it's very fair to think of them as industries which have an excellent track record of safety and imbibe from them the culture of the process sitting. So I think that should answer the question.
Thank you. And I completely agree that we learn from the best practices. We learn from different industry, different sectors, and we try to pick up. The way I gave the example of case studies where automobile industry gave a lot of quality lessons to the people in healthcare. So the next question probably for Mr. Khanna, that for the capex purchase, we have standard specification, we follow that, but to meet the clinical quality requirement, we don't have much of specification for the consumables. And we also try to maintain margin and reduce the cost. So do you think this kind of practices are going to affect or impact the patient outcomes?
I'll just respond to it in this manner, that I think if some hospital is not taking care of the cost of, the quality of consumables, I think that needs to be looked at and needs to be corrected. In terms of consumables, I understand that capex is a different one-time big purchase, but consumables have a big impact on the quality of the patient care. So the user has to be, firstly, the user has to be convinced. It is the duty of the user to try out multiple options which are available for the consumer and then recommend. Many hospitals, including ours, we would take the recommendation of the user and ask the user to evaluate the consumables on different parameters. For example, if suppose it's not only the price, because cheap price is not the real indicator. It is the price and the outcome, what is the efficacy of the thing, and so on and on. So unless the user is involved, you will have an issue. So I understand this question where it's coming from, where sometimes many hospitals will just switch the consumables because it is cheaper. There is no harm in doing that, but as long as it is done in consultation with the user, so that there is no compromise in the quality. Joy.
Yeah. So the third question for Dr. Kocher, that somebody has asked, I'm not very clear about this point, but basically what are the top 3 best indicators of life experiences of patient in terms of quality outcome? Top 3.
See, it's very difficult to quantify, Joy, as you're aware, about the top 3, but the entire concept, the relatively recent concepts of PREM and PROM, they are the end thing actually. So speaking about patient-reported and patient-experienced outcomes, if we can quantify those based on all the published criteria, that itself is a study in making. And based on those outcomes, I think we can read discussion with a lot of learnings and sir and Mr. Gautam. But to cut it short, actually, if we were to design a system based on, because each patient will be very, very specific, right? And all these parameters need to be collated and studied together to devise that experience.
So thank you very much, Dr. Kocher. And just as his voice was little breaking for the people who have joined here, he mentioned about PROMs, reported outcomes. So it is a part of the NABH, and as a best practice, you can get into that practice and you can get what really patient feel, what is really their experience. And that is something which has come recently in the last edition of NABH and which is, really going to be a game changer when you see in a longer horizon how patients feel and what feedback they give for your services. So with this, I want to conclude the panel one. I want to thank Dr. Narottam Puri, Dr. Atul Kochar, Mr. Gautam Khanna for taking time out and joining here today. It was really great listening to all of you, and I'm sure the participants also have enjoyed listening to all of you. Thank you very much.
Thank you so much. Thank you very much. Thank you, sir.
So with this, I move on to the next panel, which is design thinking in quality. So design thinking, I think, is probably one of the hot topic today when we talk about that how do you get solution to a problem, how do you manage a situation, and very importantly, how do you get something out of the box thinking and get something implemented and put it in practice. So I will not take much time, but I'll be first taking this opportunity to introduce our speakers for this session. We have Professor Hariharan. He's the founder director of Savoir Faire Management Services Private Limited, and they're in consulting and training for nearly last 3 decades in the domain of strategic cost management, new product development, lean thinking, and people alignment. So I welcome Professor Hariharan in this session. Then we have Professor Andrew Taylor. He is Professor of Cardiovascular Imaging, University College of London, and Director of Innovation from Great Ormond Street Hospital for Children. Both are like Center of Excellence, and we look forward towards them to see some innovation, some of the best practices. He has established the Center for Cardiovascular MR at University College of London and Great Ormond Street Hospital for Children. He has recently been appointed as the Director of Innovation at this Great Ormond Street to develop the digital research, innovation and virtual environments unit, completely called DRIVE, the cell gene therapy manufacturing facility, and a new pediatric innovation hub. So welcome, Professor Andrew Taylor. Then we have Mr. Erej Stalik. I don't know whether I have pronounced it correctly, but forgive me if it is wrong. He is the innovation facilitator at Systematic Inventive Thinking, an innovation expert and advocate with close to 20 years of experience of developing, facilitating, and leading innovation efforts around the world. Thank you for joining from Israel. So I'm sure it is now still your morning. So good morning to you. Good morning to Professor Taylor, and good evening to Professor Hariharan. So with this introduction, I'm now getting into the discussion. So I will start with Professor Hariharan that, there are many participants here. They are from hardcore hospital operations, management, and all, maybe very limited, idea about this design thinking. So I'll request you to start with, what do you think is at the core of concept of design thinking? Or if you can just elaborate a little bit, because I also happened to attend your training and I got a great insight from you at that point of time. So if you can just share that with all the participants.
Thank you. Thank you so much, Mr. Joy. So happy to see Professor Andrew Taylor and Mr. Salik. Is the pronunciation correct, sir? Thank you. Okay. Okay. Let me make it into 3 parts primarily. Design thinking emerges fundamentally from thinking like the designer. What is it? Yeah, punning with English. thinking like a designer means a designer typically has to have an empathy for what he's looking at. If you look at every one of us, we were all from the childhood have been learning a lot. What we learned in the first 6 years versus what we learned in the subsequent years. Definitely what we learned in the first 6 years is much more than what we learned in subsequent years. The first 6 years, our learning has been incidental learning, not a direct, rudimentary, rote learning. It's more like incidental learning. When you say incidental learning, typically what happens is we observe things, we try out things, and then we solve our problems. We have been great problem solvers till the age of 6. Our creativity was at its best. Slowly it got a little bit maimed when we got to the school, got wounded when it went to the college, got maimed absolutely when we went to the corporate, and so over a period of time get buried also. So essentially, design thinking emerges from everybody has got a creative streak to them, and ultimately apply, create solutions for real human problems. Okay, how do I do that? One is, when you look at a problem solving, it is very important to jump into the fish bowl to understand what the fish does. The most critical aspect of design thinking is the observation. When we say observation, it is observation not only with eyes, with all the senses. In the context of a hospital, if you look at it, smell makes a big difference for me when you look at things. Hearing makes a big difference for me. As a doctor, typically we tend to understand a lot by hearing, not what the patient says, but the kind of way the patient is breathing also. So we apply all the senses to observe what is happening here. So at the core of the design thinking, when you're going to jump into the fish bowl to empathize with the fish, it is very critical that you start observing things closely. Smell is a big differentiator in the case of a hospital as well, because as doctors, definitely you are trained to look at that in that sense. The third critical aspect in design thinking is what we call as fail fast and fail safe. See, when we create everything and then it fails, it's going to be a big fall. But when we fail fast and fail safe, the advantage what we have is we are able to create prototypes, make mistakes, and then do that. That's precisely what a small child does. A small child, essentially what it does is it is trying to fail fast as possible, and then able to solve that particular situation for itself. It is a lot of small mistakes and small failures. And one final point before I hand over back to Mr. Joy. See, typically hospital is a place where the customer interaction is extremely high. When I say customer interaction, it is not only the patient, because patient is not even in a position to take a decision. It is a patient, patient's relatives who are qualified from WhatsApp University, who come and confuse things for us when you're taking a treatment, when you're giving a treatment. Have you not done the test? You're supposed to do this test. Boss, I have studied for 9 years to be a doctor here, and you're studying WhatsApp University and coming and telling me. Patients' relatives, insurance companies, municipalities, doctors, the most critical stakeholder here. So there are multiple stakeholders whom I have to look at. And being a service operations, my whole process is put under tremendous strain because of what we call as customer variability. When you look at customer variability, there are 5 kinds of customer variability which create a problem in any system. The first kind of variability is what we call as arrival variability. Not all patients walk into my hospital at the same time. They come at different times. Suddenly the pressure is very high on my system. The pressure is very low on my system. So arrival makes a big difference in a service operations like hospital. Second is what kind of request the patient gives. The range of things they're asking for is a second big differentiator. Same problem, a patient will be asking for different things. Third and the most critical is capability of the patient to interact with me. Because most often the patient comes and tells me, oh, you find out what I'm having as a problem. How can I find out? You don't tell me that. Is the patient capable enough to communicate to me what his challenges are? That puts a big strain on my system. Fourth is the effort the patient has to take on his own to address his problem. Because as a customer, I need to take a lot of effort in the service operations. So some people are willing to put in effort. Some people, we always say, this patient is not cooperating. The effort the patient has to put in. So it's a simple thing like, physiotherapy, exercise, patient has to do it. He has to put in effort. And the most important, the fifth one is what we call as subjective preference. A patient says, the hospital did not treat me well. Hey, what do you mean by this? The receptionist did not say, wish me when I entered. That itself is what he's looking at as a critical aspect. When I call, the nurse didn't turn up. See, what he calls as a critical service is different from what I may call as a critical service. So these things put tremendous pressure on the system in the kind of hospital. And design thinking works very well, where there are a lot of unknown knowns and unknown unknowns prevail. When I say unknown knowns, I mean, I don't know what the challenge is, but the patient knows it. Unknown, neither of us know what it is. In this kind of nebulous situation, design thinking works very well. Over to you, sir.
Thank you very much. And thanks for making it so simple in a short span. So I move on to Professor Andrew Taylor. I expanded the full form of drive. I have shared with the participants what you do, but can you tell us for our own benefit that what is this drive you need at Great Ormond Street Hospital?
So good afternoon, everybody. Thank you, Mr. Joy, and thank you for the very kind introduction, and lovely to meet the other panelists. So just a very quick bit of background. So clearly Great Ormond Street Hospital is a dedicated standalone children's hospital, and I guess probably up there in the world with the likes of Boston Children's and Toronto Children's. So just to give us our context, as it were. One of the things that we've been really keen to do is, so about 4 years ago, we introduced an electronic patient record within the hospital. But we were very aware that that would, to a degree, get rid of paper in the hospital, hopefully make some of our processes better. So at that time, we had 400 and odd systems that people would enter data in, and we wanted to go to one. But we were also trying to think ahead and think, actually, what's going to be important about that data is how we use it. And particularly how we might use anonymized data, because from a research perspective, that might help us do some of the things that we might want to do as we go forward with sort of data-driven care. And so we created this unit called Drive, which is about data research, increasingly about innovation. So I think a lot of the things that we've just been told, so hospitals are incredibly conservative. They don't really do fail first. That's not their mentality at all. But for some of the things that we want to do and move forward, that's really important. And actually, the other bit of this is, and I'll come to this, is I think you really touched on a really crucial point, is actually people come to our hospital expecting incredibly good care. They just take that for granted. What really concerns them is all the things you touched on, is the receptionist, the food, all of those things end up being the things that they kind of, they consider as the quality of care. So the sorts of things I would say that we've really changed, and some of this sort of happened through COVID. And I think COVID, they're clearly so horrible for all of us, actually from a hospital perspective, made us do some of this thinking fast and actually failing quickly and then going off and finding another solution. So clearly the one for me would have been is virtual clinics. So we did some work just before the pandemic where we actually thought virtual clinics would be super useful, help our patients. So we see patients from the whole of the UK, travel long distances, so on and so forth. Can we help with virtual clinics? When I surveyed the patients, they said, no, we like coming to Great Ormond Street. We see the consultant. That's great. That's what we want. And when I spoke to the teams that might be able to do this, actually, let's take our electronic patient record, safely join that to something like Zoom, which is what we've got here. How can we make that work? And I was kind of told that'll take a year, 2 years, something like that, Andrew, to do. COVID comes along. Clearly, suddenly that becomes a priority for us, doesn't it? We know that patients don't want to come to hospital, even in the pediatric world where they weren't super affected, but they don't want to come to hospital. How do we change that? And within about 3 days, we had a system which safely linked Zoom and our electronic patient record and brought in a new quality of care for people. And when you go back and ask the same children now, they'll all go, yes, actually, virtual care is really good for that particular thing. Some things need to be done in hospital, but other things don't. So that's kind of one of the examples of how we've changed stuff. Another example would be, so if I look at, we hold up in my cardiac world, so in my clinical world, we hold a weekly meeting. And in that meeting, we look at everything from the week before that's been the good things that have happened and the things that maybe we need to work on. So particularly from a surgical or an interventional perspective, complications that may have happened, or mortality. So a morbidity and mortality meeting. That meeting was, the data for that meeting came from some person looking through the notes when we had patient notes, picking up all of those things. So when was there a cardiac arrest? Did a patient go back to theatre within 30 days? Did somebody go back to all of that? They would look through and go through that. Once we had an electronic patient record with that data then coming into our trusted research environment, we were suddenly able to automate that. So now, as opposed to a person having to do that, that meeting can now be automatically generated. And what's really interesting about that is now we've got timelines for each of those patients about their care with their patient feedback. So I heard at the end, Mr. Joy just mentioning proms and so on and so forth, all integrated into one system now that gives us a real good overview. I think the important thing for that is also, if I could now have benchmarking, so my central line infection rate for my particular hospital, but I've got benchmarking from somewhere in Delhi, and actually somewhere in Delhi is actually doing better than we are, and actually the line infections are it's not a competition for me. My immediate question there is, what's happening in that hospital? What might I need to take as best practice so that I can improve the quality of care for the patients that I'm treating? And then the final example I'd kind of use, and we sort of touched on it, is how do you predict sort of volume of patients coming through? Because actually, particularly as a hospital, that's really important. So if I take, now we've not had much of it because of COVID, but if we take another seasonal respiratory illness, so there's something called RSV, the respiratory syncytial virus. In the UK, every winter, children get affected by this, but it's really difficult to predict when that surge is going to happen. And what we've done is taken our previous experience as our hospital, taken data that's from the meteorological, so what the weather's like, what the conditions are like, when the temperature drops, when people start going indoors. And if you combine that bit of data, you can actually predict 2 weeks ahead of time of the surge for RSV when it's about to happen. And that's super important, because then you can gear up your ambulances, your staff. You know that maybe you shouldn't be doing routine operations at that particular point. So instead of this surge coming and us all running around trying to sort that out, suddenly you've got some predictive models that, again, really affect the quality of care for the patients that we want to deliver, or we want to deliver for the patients. And then my final piece about this is, I think all of this data is taught us that clearly, and we know this is a continuation, this care. And I think as we move forward, we're going to see care delivered at home, care delivered by primary care physicians, care delivered in hospital, almost as a continuum that we need to integrate together. And importantly, I think if we begin to do that, we'll also do that bit that we know is really, really important, which is actually how do we deal with prevention? Because that will hopefully help us with all of those things of our patients coming in. So from my perspective, that data, that innovation, many of the things that we've just heard about from actually how you do the design around that are really, really important. And I think we can begin to bring together. So thank you. That's me for the moment.
Thank you, Professor Taylor. I think it is really great to hear the kind of work you are doing in Drive, and thanks for driving it. So I'm sure that there will be a lot of lateral application and adaptation of that in many other institutes. So now I move to Mr. Erez, and we always look at innovation and kind of contribution in terms of thinking, new process, everything from a country like Israel, and you are representing there. So my question is going to be, do you see that healthcare organizations are adopting innovations as a core strategy to improve quality of care in the Western world? And If yes, can you cite some of the examples or give some cases what you have experienced? Over to Mr. Ires. You are still mute. You need to unmute yourself.
Thank you for having me. So I want to start by saying that I think that the main difference between Western countries and the rest of the world is maybe on two levels. One is in pace of innovation. So because when you have more resources, you can probably adapt new solutions faster. And the second one is the confusion between innovation and newness. So I want to say something that I hope won't sound as criticism, but from my point of view, new and innovative are two different things. So when I change something to improve the process or to solve a problem, that's what people do for thousands of years. That's not innovation. That's normal continuous improvement or process excellence. With innovation, we expect something that has some other qualities, additional qualities. When my hospital or my bank is now offering me a new way to interact via my smartphone, if it's innovation, I would credit it to the company who developed the technology. If you buy technology, you're not being innovative, you're doing the right thing. Just like, we're reviewing surgery protocols, you're supposed to do it. So when I talk about innovation, I want to focus on things that are kind of beyond these reasonable and good solutions. And I think that in that sense, I see little difference between the Western world and the rest of the world. My first project in healthcare was almost 20 years ago in Mumbai. And it was as advanced as in any other country. I've been working in the healthcare industry innovation for many, many years with Johnson & Johnson and Medtronic and hospitals all over the world, mostly in Israel, India, and Singapore and the US. So I think that many times we have a lot of innovation that is not fancy, it's not sexy, it doesn't have a touch screen, and we tend to overlook. And in that sense, I think that there's a lot we can do by recognizing innovation that is already happening and trying to boost it up and trying to learn from it. You can learn from other hospitals. You can also learn from what has already happened in your hospitals and formalize it in an interesting way. So that's one thing that I wanted to say. The other thing that I wanted to say about specifically healthcare is that when we analyze different applications of innovation, one of the things that we discovered is that surprisingly enough, the areas when you see innovation not only succeed more, but also working faster is counterintuitive. It'll be the areas who are heavily regulated: food, healthcare, finance, energy. These are areas who perceived as very stagnated and very bureaucratic. And the reason why we see innovation works faster and better there is because unlike normal perception, constraints enhance creativity. It's not about freedom. When you have unlimited resources, you don't need to be innovative. When Steve Jobs worked on inventing the iPhone 2002, 2003, and he wanted to have a touch screen on it, he didn't need to be innovative. He bought the technology. But when you have limited resources, then you start thinking, and you start thinking differently. You break fixedness. You take advantage of existing resources in a smarter way. And for me, this is the highest level of innovation. I think in India, you call it Jugad. So imagine a very elegant, very deep way of doing Jugad and doing it systematically, intentionally. So I think that really helps in creating and applying innovation. And I think that one of the reasons we see that in Israel maybe a little bit more than other countries, not a lot more, is that we tend to think in that framework of working within constraints. And when you surrender yourself to it, there's so much you can do with the resources that you have.
Thank you very much. And you have very nicely brought out the difference between innovation, jugaad, and when you do something, a change in process, change in practice just to meet your requirement. And I'll come back to you with the other point soon. I move on to Professor Hariharan once again. And a question to you. And in my personal capacity, I've heard some of the examples what you have brought in design thinking for a hospital or for a healthcare setup. So question that in a hospital setup, how a design thinking approach can help to give solution to prioritize the patient needs.
See, as I mentioned earlier, that central theme of design thinking is empathy. Empathy is made up of three aspects. I am aware of the problem, I articulate the problem, and I take action on the problem. If there is no action attached to empathy, it becomes sympathy. So when a patient comes in, primarily a patient is absolutely stressed. He is desperate and he is not in a position to articulate what his problems are. Most often he understands only the what you call as a manifestation or symptom. So how do I go through that particular process of doing that diagnosis is the most critical part. What I mean here is that without a proper diagnosis, going for a treatment, of course, is extremely dangerous, no doubt about it. But most of the diagnosis which happens, I'm telling this primarily from a perspective of a patient. It takes longer time for getting the results also for a particular diagnostics. The diagnostics is disconnected from the patient need in that sense. In many of the hospitals I've seen. When I say diagnostics is disconnected from patient's need, what I mean by this, diagnostics follows their processes. As Professor Andrew Taylor rightly observed, that is a pretty conservative place a hospital is. In a conservative place, we tend to necessarily follow the protocols, no doubt about that. But sometimes the system takes precedence over purpose when it comes to protocols. So the nurse has been trained to wake up the patient politely. She comes and wakes up the patient. Hey, patient, please wake up, take the sleeping pill and sleep. The very fact that the system is taking precedence over purpose here. So the point is that how do I prioritize is purely driven by how do I get to the cause of the problem faster. Again, I just draw from Professor Andrew Taylor's perspective about what he call using data analytics for identifying when this surge is going to happen. Typically, we are from Mumbai, Joy. In the case of Mumbai also, we have a dengue season starting. We have a malaria season starting. Okay. Come to what you call Delhi, around this time, we have respiratory problems starting now. Now, the question here is that, so typically what happens when a patient comes in, I first test it for dengue before anything else. So my prioritization is driven by and swayed by what is happening around rather than the real diagnostics. So in a hospital context, how do I apply design thinking is essentially the processes which needs to be done faster has to be done faster. Diagnostics is a classic case here. So applying the design thinking principle to understand the patient's real problem of understanding what is happening and what is not happening, understanding the symptoms and converting them to problems. That is where design thinking perspective helps in the context of a hospital, which many a times is missing. Yeah, over to you.
Thank you, Professor Hariharan, and you have given some of the very, examples. Probably we know that, we practice that every day, but we don't approach it in such a way that which can make a huge difference in our outcome, quality, as well as in the patient care. I move on to Professor Andrew Taylor once again, that with your experience of this innovation on what you are driving today, do you practice, have you observed that something like, how can we align this concept of innovation into improvement in quality healthcare? So can you, little bit articulate that?
So the first thing is, let's be not wanting to be controversial. So I think from Erez's point, I guess in a pure way, what he describes as innovation, I think it is a little bit broader than that. In that I do think, maybe we're saying the same thing in some ways, is that I think innovation you can have innovation through the repurposing of other ideas. So they may have been innovative around the touch screen, but actually bringing it all together as Steve Jobs did into the iPhone clearly was a bit of a game changer, though probably all of us who had a Palm Pilot at the time were waiting for an iPhone to come along. So I do think it's a little bit broader. Just as another reflection, I do think though, and also having interacted with Israel on certain things, and there's an incredibly good book around Startup Nation. I do believe there's something around Israel, and you're right, around the mentality that's almost not reproducible anywhere. There are potentially lots of reasons for that, but it's a very interesting mentality that I think you're right. It's about solving problems, but it's also there's a desire to drive that at a real pace that I don't think we see everywhere else. And so, though I'm sure all of those conservative forces, particularly in healthcare, are there, I think that there are people that are very willing to drive them forward in a different way. So I think it's slightly broader than what's defined, which then comes on. So in a funny sort of way, I think the other bit of this is you can almost join up across a piece, really, innovation as a driver, as the place that is working with new ideas. Many of those won't come to fruition, but is actually there as a driver. We've got that bit for whatever it means. And to me, this is partly about design, which is transformation that sits in the middle. So if I'm a hospital, what structures do I need to transform to make sure my innovation works? And then at the kind of other bit of that is, and the continual process, which I think you're probably referring to, that's not innovation, is improvement, which is going on. I think that the biggest struggle for hospitals at the moment is that there's no shortage of super ideas, actually, interestingly. There's no shortage of really good people. Yeah. We're really, really, really struggling to implement it, really. And that comes from all the things that we've sort of said around design, around being conservative, all of those things. And I will just go back to COVID in a funny sort of way. Because at that point, and as the lead for a hospital at that point in time, almost daily everything would change. But I saw a sea change in the way people dealt with it, and that they kind of accepted that would be the outcome. But I had teams who would come, who would often historically have presented, here's a problem, please can you sort it out? With, here's a problem, here's our solution that we might want to use to take that forward, our improvement, whatever it is. Actually, let's try that. Now, we know the rules might change tomorrow because the government might have changed the rules, or COVID might be in a different place or whatever, and we'll deal with it tomorrow. But actually, here is our position at the moment. And I think from an improvement perspective, that mentality of actually being able to try something and drive it forward is really important. This is not about innovation. I think my final point, and I've also touched on it, it's somewhat boring in one sense, but actually benchmarking is super useful in this perspective. And I think for me, and I've sort of alluded to this, I think historically people have used benchmarking as almost as a way to say we're better than you, whereas I really see benchmarking as an ability to choose who does something the best, because we'll all do something really well, so that we can all bring ourselves up, as it were. And so for me, that improvement bit, that benchmarking, and therefore really accurate data that's very timely and done and provided as quickly as possible, is super useful to help that improvement cycle. Because it does say, and as I alluded to before, a hospital does this really well. What processes do they have in place that does that really well? And then the other really important part of this is, I'm going to share that with somebody now, so that I can make that improvement happen within that other organization, so that we can all elevate ourselves up. Because I'm completely sure all of us as individual hospitals do some things really well and do some things less well. And actually by coming together and collaborating, we could make things better. And that's my other point. I think the data and our ability to share now is super important, and we're on the cusp of being able to do that.
So if I take one of the points you told, and I just picked up in between your comments that I used to think that means I'm talking about now in India, we have a lot of great ideas and a lot of, new thoughts, but we find it difficult in terms of implementation. And I see your experience is also the same, that you have a lot of great ideas and thoughts, but it gets stuck there. So are you looking at some solution, some sorts of, approach by which you can come out from this situation?
So from my own personal perspective, partly because we sit on a rich data resource of pediatric data, and here's a really concrete example that comes from India. So we were sort of recently approached around something where somebody felt that they had come up with a decision support algorithm that would look at patients who had or were on a journey around liver failure. And the algorithm was actually what might be the point at which time a patient might need a liver transplant. Now, interestingly, liver disease is the one thing that we don't do, and it's done at a different organization in the UK. It's from a pediatric perspective. But the next question was, actually, could you do the same thing for renal disease? We do a lot of renal transplantation. Is there a way for us to begin to manage a patient earlier so that you can inform the patient about what's going to happen, so you're prognosticating for them? You can gear them up for everything that's going to, and you can plan those treatments from a very limited resource around renal transplantation, for example. And so what I would see is actually if somebody's got such an algorithm, and I think particularly with India and within some of the high-tech things that you're developing, actually we have the perfect environment to test that for you in a sandbox that says, actually, this does work. You might have done this in adults. This really works in children. We've demonstrated with our historical data that it's super safe, and actually that decision support can go ahead. And the other bit for me is, I think there's a lot of anxiety, particularly around, and I'll be sloppy with the word AI, and how that's going to make things happen. I think, though, in that, particularly as we move forward, we're going to do that hand in hand with clinicians. Here's my example. If I go onto my IC intensive care unit, and I look at a patient who's pink, smiling at me and moving all four limbs, and the saturation monitor says their saturations is 50%, the saturation monitor is lying to me. It's wrong. It's not what I've got a pink child in front of me. They're perfect. So actually, the same with all these decision supports, I think it's really important that we use them embedded in clinical systems. But going back to your original question, I think there's lots of, again, collaboration. There are lots of things where people will design stuff. And actually, for us, in our very data-rich environment, we'll be able to test that for somebody and then be able to work with them, potentially say, actually, this is really, really neat. Or, as we've said earlier, this is never going to work. Go away and think about something else, because you've got to fail fast. I hope that answers your question. Sorry.
Yeah, of course. So I move towards Mr. Erez, and my question to you is that, design thinking in quality involves a lot of transformation, a lot of change in mindset, a lot of, new kind or set of activities, which is always exciting in the beginning, but in a long term to sustain and maintain that, it becomes difficult. That is from my personal experience. So how can an organization overcome this and makes it as a culture of the organization?
Okay, so I'll start my answer by building on Professor Taylor's comment. So one thing that he mentioned that I think that is very important, especially if you want to change the culture, is benchmarking. And the same benchmarking that you apply in medical fields, you also want to apply when you apply innovation. So, if you're a surgeon and the only tool that you have in front of you is a scalpel, I guess that every interaction with a patient will end up with a surgery. So I think that one thing that helps to create a culture of innovation is providing members of the organizations with multiple tools. And we know that some tools, design thinking, for example, is an amazing tool for problem solving. But when you need other types of innovation, there are other tools that could be more effective. That also include, different people with different thinking tendencies or different skills or different mindset. So one thing to create a culture of innovation is to provide people with the skills and the mindset and the tool set that they need. That's one thing. The other thing that I think is necessary is to show results. The best driver for innovation is by being able to show results, big and small. If you're only focusing on breakthrough, you're not very likely to do anything. But if you understand that the only difference between a small idea and a big idea is size, then you're on to creating a culture. And it goes also the same way that we reward innovation. You know, if you run an innovation competition, that will work for you maybe the first and second year, but that's not sustainable. On the contrary, because when you have a competition, you have 2 or 3 winners, and the organizational message to everybody else that they're losers. Okay, so it sounds reasonable, but when you want to create a culture, it doesn't work this way. And the third, I think, aspect of creating a culture of innovation is creating support mechanisms. Now, I think that in some industries, and again, I agree with what's been said before, failing fast or embracing failure is not an option. So I can tell you that from my experience working with hospitals and with pharma companies, we just changed the way we approach it. We say from now on, we treat every initiative, every innovation idea as a science experiment. It's not, we're not gambling here. It's a science experiment. We know how to do that. We create a protocol and we do it responsibly. So it reduces a lot of stress. It's not you just try it and let's see what happens. No, you don't do that way. So sometimes changing that can help you to do better. And the last thing is that I think that at least for me, an idea is only something that include the what and the how. And many times we only focus on the what. So if you feel that you have your pace of implementation is not sufficient, apply innovation there. Reinvent the way you implement. In the SAT mantra is don't do innovation. Innovate in what you do. Innovation is not an organizational objective. It means to an end. And if it works for you, you will continue doing it. And if it doesn't work, you will stop. If you would stop innovating tomorrow, nothing bad will happen. You would still improve and still progress, maybe not as fast as others. But it's not a necessity, it's a choice. And if we want to create a culture of innovation, then we also have to make sure that we not only start bottom up, but also top down. When I meet with the team of managers, and they ask, how can we improve innovation in the organization? My first question is, what did you do innovative recently? How much time do you take in a month? How many hours a month do you invest in just sitting and thinking without any distractions? If you don't do that, why you expect somebody else to do that? And I have to tell you, I know it's a long answer, I'll stop now, but while I was listening, I made a list of 8 or 9 different aspects of innovation that can and should be applied in hospitals and contribute directly to patient care. So things like queue management, triage, training, patient record and data. How do we manage data in smarter ways? How do we find new models of owning data? How do we respect patient privacy and still come up with brilliant ways of getting real-time data, which is really hard? How do we change the business model of the hospital in such a way that will not only benefit, the employees and the hospital, but also the patient? And there are ways to do that. Amazing. And some of them, at least the most interesting for me, are those who require very little investment and heavily rely on existing resources.
Mr. Joy, can I just comment? I think everything that's just been said there is a really lovely summary of actually the cultural bit. So very nicely done. Thank you very much. And actually one of the things that somebody starting relatively new in that and having some of the baggage of innovation of how people has been to go out and find other places that, so Israel has been a real eye-opener to us, but it's just to go out and see what the other, how others think about this, how and how people are taking it forward. And I completely agree with you. In a funny sort of way, in the world that I exist in at the moment, there are three bits to it. Data, I feel, is the oil of everything that we're going to do. Actually, if I stop doing the data bit, that would be detrimental to the hospital. But as you say, the innovation bit, it could stop tomorrow. I think we'd be a less good hospital and we'd be thinking in a less good way, but it could quite easily. My other bit, which is around gene and cell therapy, again, that can't stop because that's about driving treatment. So this little in-between bit, I completely agree. And it's a very lovely summary of that culture, the difficulties sometimes of that cultural change. So thank you.
I keep reminding myself a saying that I heard once, that the world still need more potato chips than computer chips. And I think it's a mixture of both. So, yeah.
So thank you.
I just want to add, Joy, I just want to add what Mr. Harris was talking about. A couple of years back, I was reading a book written by a person called Matthew Syed, Black Box Thinking. It's one of the phenomenal books, which is a must read for every hospital. Andrew, you want to add something on that? Why this last statement?
I think he was a table. I've met him, so I think he's a table tennis player, wasn't he? He used to be. He's a very good. I can't remember. Anyway.
So this Matthew Syed's books talks about comparing two industries which are very interesting, or poles apart. One is airline, other is healthcare. The key point he was talking about here is that in the context of, since Joy talked about the culture aspect of it, one of the biggest difference Matthew finds in this whole difference between the two industries is the approach towards the failure. In the case of an airline, the kind of reaction they have for the failure is something phenomenal. That is, every accident is considered as a way for learning further. They go back and modify the system, modify the aircraft design, modify the protocols, and ensure that the accident does not happen because of the same reason. But whereas what Matthew is talking about here is that he has given some very interesting statistics where he talks about, as of 2014, around 400,000 deaths happen because of misdiagnosis and hospital mistakes in US. It's a huge number. Okay, he quotes it from some specific, what he call research papers. Okay, I'm not getting into the veracity of the numbers, but the key point he's making here is that the approach towards a failure in a hospital is totally different between the approach in the case of an aircraft. That there's no great effort taken for doing a root cause analysis after an event happens in the case of a hospital. The patient dies and goes back. Care is human is the title of that particular research paper written in 1999, earlier research paper by the American Medical Society. Only brought that paper out, which talks about the kind of deaths which happen in hospitals primarily. So the culture part essentially comes from how do you react to failure and how do you handle failures? And what do we learn from the failure? What is the protocol we have for learning from failures? Because one of the key theme in design thinking is primarily a small child. If you take a small child learns a lot by failures. The same failure a child does not repeat again because it is learning from the failure, working on it and modifying it. So what is the process we have? Formally a protocol to learn from our failures, which is critical for quality ultimately. Am I correct?
Yeah, so a very nice example. So I'd say Matthew Syed was a table tennis player. I just checked. He wasn't used to be a table tennis player. He's done lots of talks, and particularly with my old medical director is a chap called Professor Martin Elliott. Just quickly on that. So I think you're absolutely right. There are ways to learn, particularly from other industries. So just from an improvement perspective. So in a very specific example, in a very specific setting. So clearly when you're operating on a child with congenital heart disease, when you're doing that operation in theatres, you've got an entire team who've just been with that child, often for 3 to 4 hours. They know everything about that child. We take them out of theatres and we move them into an intensive care unit. And suddenly a whole other group of people now take control of the care of that child, who haven't got that 3 hours, 4 hours experience. And what we found is that, exactly as you described, in some of the incidents, so coming through our weekly meeting that we're coming up, was actually communication across this wasn't great. So 2 of our team one of whom does risky business and has had Matthew to speak on this. And actually this airline analogy is very common in that world. Actually said, so who does this handover? And looked at Formula One. So a Formula One team immediately they hand over without, so actually we worked with a Formula One team and actually paired up and worked out how they transferred that information in very, very short time space, and how could we do that as we fundamentally did that handover between the operating team and the team receiving the patient, and actually change the way that communication works. So I completely agree with you. We've not been great at doing that. So how do we do that? And I think what I see from the airline industry in particular, maybe it's slightly different now, is that at least they've got the headspace and the time to do it. Whereas often in the, how could you take somebody away out of their busy clinical day to deal with this problem, no matter how super important that would be? And I think that's the conundrum we sometimes deal with. But it's learning from other industries is super important.
The key point, most often we are swayed by what is urgent, not what is important. Somewhere we have to stop to think as to what is important. When we think about what is important, then root cause analysis and failure understanding. Failure is the only way to learn things. Failure is the only way to grow things, which was absent typically. The key point he was bringing out in that whole book was how this point is missing in clinical treatments.
You make an interesting point though. So actually at the M&M meeting I was describing, the very first thing we would do is actually describe the number of patients who had been through the unit that week without a single incident. Usually somewhere, and we would count every tiny drug error, anything. It's usually somewhere between 85 to 90% of people. And then, as you say, we would work on those people who maybe didn't have it wasn't a perfect journey. What was there to learn and how could we change things? What is very interesting though, is I am sure though there is something you can learn from when it goes really well, but we tend not to do that. So that's also an interesting part of this.
So it is very nice to moderate a session when the panelists take away and the moderator goes to sideline, and so much of nice discussion happens. So I was really enjoying listening.
Sorry, sir.
No, that is really nice, and it was great to hear from all of you. And coming back to Mr. Deras, that he mentioned 2-3 very important things at that point of time. That culture of innovation, the culture of all this, whether it should be bottom up or top down. And second, very interesting thing, and I think most of us, we commit that mistake, that when we are in a journey and we try to go for innovation, we recognize maybe the first, second, and third one, we forget about the rest of them. And when we do that, probably the culture, probably the interest amongst your people goes down when they see that they are not recognized. So probably to bring the culture, we need to have some sorts of incentivization which can make people more enthusiastic towards this journey. So with this, I move on to Professor Hariharan once again, that you have done, I know, research on design thinking and its application in healthcare. You have shared some examples before, but can you give some examples where it has helped in terms of improving quality outcome in healthcare or any other industry, if you want to share with the participants?
So I will give, for the taste of difference, I will use a different industry altogether. Okay. This is an industry which is primarily, from Africa. Okay. Closer to Salik and rather than us. So in Africa, we are doing some work with a product called hair extension for women. When you say hair extension, typically African women have short hair and they want to extend it. So this hair extension is a must for them. So one of the biggest challenge fundamentally is we are trying to look at relooking at the product portfolio and see how we can expand the product portfolio. All along, the design is done by a designer who was a stylist earlier, who sits in the office and then creates a design. We made a modification. We said, let us do one thing. Let us go to the ground and observe what is happening there. We went to the ground, which is primarily the ground is where the saloons are doing this exercise. The key point I'm trying to make here is that how you learn a lot by observing what is happening on the ground, observing the periphery. When we went down to the ground and observed there, what we found was it was a pretty elaborate process of doing this whole hair extension. Sometimes it takes around 3-4 hours also. And imagine you are pulling the hair like this continuously. It's going to be paining. So these girls take around 3-4 Panadols to overcome this headache, which is caused by this. Longer, more designs, longer it takes for them to do it. And when they're doing it, they lose the grip also. Therefore, they can touch some powder or some kind of a agent so that they can hold it properly and then do it. We did the emotion exercise of asking the boyfriends and husbands of these girls also about this particular experience. They said that it is actually stinking after about a few days. What is stinking after a few days is because you are touching something and then doing it. The company is not even aware that this is how it is being done on the ground. So ultimately, when you start immersing into the whole process to understand what is being done on the ground, we came to a conclusion that A, the grip is creating a problem for the people on the ground level. Therefore, they are not able to do that clearly. So they have to use some external agent for doing the grip. And they need volume. Therefore, they are doing something more of adding, mixing some other fibers which are not really conducive. So when these two in a perspective came up, then the product design modified totally to ensure the grip is improved and the volume is improved. Why I am telling this is, it is done, the design is done by a stylist who was a stylist for 30 years. But still he could not look at the context of the customer's requirement. Coming back to the hospital context. In the hospital context, if you look at how do we define a quality ultimately? Is life critical or quality of life critical? Most often we are always at a crossroads, especially if I'm treating, because I have a personal experience of a few cases in the last few years in my home, not because of COVID, even pre-COVID. The doctors were working in silos, typically in the hospitals where I went. The neurosurgeon comes and checks the record. The next person comes, checks the record. They never meet each other. There's no protocol or mechanism where consistently and consciously there's a meeting of patients happening, meeting of doctors happening across domains. And in the process, I end up treating a body and not a person. Are we treating a body or are we treating a person? So quality ultimately means what? I have to take a call. Is it leading towards quality of life or is it leading towards life? After 75, 80, quality of life is more important than life. That context is very critical for me when I'm getting into a patient care. So the palliative care or the geriatric care is actually a big missing link in many of the hospitals primarily. How do we treat an old person? So in that context, if you look at the design thinking context, so what we did was we discharged my mother-in-law from the hospital and then we kept her at home for nearly 3 months. She recovered very well before she breathed her last. But during the period, she was happy. What we require is a compassionate care at that point of time. So most often we focus more on the life rather than the quality of life. So what is the priority? For somebody who is going to be 40s, life is very critical. But somebody who is going to be 80s, quality of life is more important than the life also. The point is defining that customer requirement, defining that customer priority is very critical in this care. So design thinking in that context has to take into consideration what is that are we treating? That what is that we are treating? When it gets missed out, then it leads to dissatisfaction.
Thank you very much, Professor Hariharan, and very apt example, especially which is related to healthcare, because very often, as you told very correctly, we are always into the mindset of how do we treat a patient and try to give them a life back, but what about the quality of life? Thank you for that. And before I move on to Professor Taylor, I want to tell participants that you can drop any question if you have, and that we can ask the panelists. So you can feel free to type that. So now, Professor Taylor, that you have spoken about data mining, and that is something what you are doing extensively, which is helping your innovation. Can you elaborate and tell us that how this innovation in terms of example has helped in improving quality and clinical outcomes?
I'm going to choose a slightly weird example, but it's something that's really changed or has the potential to change things in the hospital. So if you think we're, when we deliver food in the hospital, well, actually coming back to the very original point, what do people complain about most in the hospital? It's the food. So actually, we still have a relatively old-fashioned way of doing that. We deliver it at the expected meal times, and it's not super flexible. We often don't deliver food that patients might have a need for, so on and so forth. So clearly, we've all experienced the revolution, or certainly in the UK, of whether it's there's something called Deliveroo, but fundamentally, people coming to our own homes on their motorbikes, however it is, to deliver food that we require to our doors. Super flexible for us as individuals. So actually, our catering manager came up with the idea of let's do that within the hospital as a app that will deliver for that patient and for the clinical team a better a food content for somebody that actually is tailored to them. And clearly the initial worry about that was that that would create demand and remove how you manage that particular unit or how you manage the catering staff and so on and so forth. But actually it's transformative. Just by doing that and the engagement we've had with patients, the ability to deliver a really, really important part of patient care, just what people eat and how they do it, has been, in the small areas that we've tried it, has really transformed that care. So I think that is, and the way that we've done that is through using the data that we've got. We've done an awful lot around prems and proms, which automatically comes in from a data perspective to give that feedback to ensure that we're doing the right things for patients. And one of the things that I've been really keen on, so one of the things that was sort of one of the first appointments into our team was actually somebody who will do this evaluation. So there's clinical and patient evaluation, because you can have the best ideas in the world, but if nobody's going to use them, then they're to a degree pointless. So I think that's been some of the things that have really transformed through understanding that data about how people are using how people are eating, what is the waste with food, so on and so forth. What is the new idea that might transform that? Evaluating how patients deal with that, and evaluating for us, actually, and we're already seeing it, a reduction in waste, and interestingly, a real increase in the catering staff's feel that they're engaging with patients now, delivering a service that they like, and actually taking that forward. So it's a strange example, but it's really changed something within the hospital that was something that particularly patients were not happy with.
Thank you. And some of the great examples what you have given. So I move on to Mr. Irez with the last question of this panel, where I'm going to ask a very specific point on how can a simple tool or method like problem solving help in quality improvement, especially in healthcare, and if there is any example.
Yes. Okay. Yeah, I have an example, and I have an example from working with a company in Bangalore, India. This is a company, it's a software house who develop, among other things, software for CT scanners. And the problem was that the problem started as a business problem, where apparently when you scan for colon cancer by CT, the success rate or the recognition rate is relatively high. It's a little over 90%. Yet there are less than 10% of misdiagnosed or undiagnosed patients. And when you look at it globally, we're talking about tens of thousands of lives every year. So the idea was, once we understand the problem, let's see what we can do to overcome that. And again, the constraints were very clear. You cannot touch the hardware, you can't touch the doctor, the nurse, and of course you can't touch the patient. So you're only constrained to work with the data that you have and with software. And I think that what changes the way of thinking was changing the perception about problem solving. Maybe I'll just start by saying that there are 3 good ways to solve problems. They are equally good, so no, it's not that one is better than the others. The first one is the one we all know and use all the time. You identify the cause and you try to eliminate it. Now, in simple problems, usually, or sometimes you can eliminate the cause and solve the problem. In complex problems, which are the problems that you and I deal with on a daily basis, usually the cause is negative and necessary at the same time. We can't get rid of it. So in these situations, what we do is we try to optimize the situation. So maybe less pain, maybe less time, maybe less cost, but that's what we do. We rarely think to try and solve problems in the other two ways, mostly because no one ever taught us that they exist, because they're so counterintuitive. So the first way to solve a problem is by identifying the cause and eliminating it. And it works for some problems. The other way for solving a problem is to disconnect between the cause and the effect. So the cause will still be there, but without negative consequences. Now, both psychologically and cognitively, we rarely come up with solutions like this. And the third way to solve a problem is to reverse the relationships between the cause and the effect. In other words, the more cause you have, the more negative effect you have, the more positive outcomes you get. Now, this is revolutionary. I think that the most genius solutions I ever encountered in my life are based on that logic. Now, we never learn how to think the other two ways. We never learn any tools that condition our cognitive scheme to actually consider that as possibility. So we don't do that. Now, with this team, with the software engineers, this is what we did. We tried to look at solving the problem in more than one way, not only by root cause analysis, which we all do anyways intuitively, with tools and without tools. And what they came up with was amazing. Basically, they said we already have all the data of the scan in our data repository. All we need to do is build the same data in a reverse order. So when the radiologists go and scan the CT results later on, if there is any polyp or anything that is abnormal hiding behind the fold or covered with something that you can't see it, you can't see it looking forward. But much like a rear view mirror in your car, you will be able to see it in a small frame on your screen designed as a rear view mirror. Now, getting to this idea was amazing because it was a direct result of literally changing the way we think. And by the way, I have to say that the only way to change the way we think is by an external manipulation. Being aware is not enough, okay? So, and when they realized that, first of all, the clinicians in the room realized that by just simply by doing this, they can probably add another 5% to their success rate. The software engineers were celebrating because apparently the technology to make that happen is in public domain since the 80s. So the way they said it, if we have a bad programmer, we can do it in 2 days. Otherwise, we'll do it in a lot less. And for me, this is a beautiful example how you create an amazing innovation that saves thousands of lives every year with zero cost by relying on existing data that you already have and existing skill set that you already have. What you do need to change is the way you look at it. You need to expand the way you think about problems. You need to expand the way you formalize problems. You need to learn more ways of approaching problems. And then you need to learn more ways of solving problems.
Excellent and beautifully narrated. I don't think it needs further clarification, extension, or elaboration. Thank you very much, Mr. Iraj. And it was really very clearly stated, as answer, which probably has been understood by all. So we have come to the end, and there were 2 questions, and I see Professor Hariharan has already answered, but one is really eye-opener for me. The question was, in design thinking, optimum quality delivery for the public, does it change between different GDP countries? So the answer he has given nothing to do with GDP, but the most astonishing fact that he has answered the country which uses design thinking maximum in governance is Bhutan. So probably on some other session, I'll try to understand how they do and what they do. And really, it is great to know. I didn't know about it. But before I conclude, I must say that probably days are not far the way design thinking innovation has taken center stage in several industries. Probably for the hospital, for the healthcare sector, we are also going to see that soon. And probably this is the time for all of us to inculcate and get into the environment of this design thinking, innovation, and problem solving approach. And then we can do that with the help of data mining, the way Professor Taylor does. We can approach the way Mr. Erage is talking about, and I'm sure it will take our healthcare delivery into a different level. So before I conclude, I want to thank Professor Hariharan, Professor Andrew Taylor, and Mr. Erage for joining here today. And that is also with a very short notice. We are on behalf of PD Hinduja Hospital. We are really thankful. And for your information, we are celebrating 1 week Quality and Safety Week. And this is one of the very interesting session, what we call as a quality forum, where people from across the country, as well as we have this time few delegates from other countries also, they have joined, they have participated, and they have got benefit of your knowledge, what you have shared today. With this, I want to hand over this session to Dr. Sapnil.
Thank you, sir. Thank you, Mr. Joy. And thank you to all the esteemed panelists for taking out their time and sharing their valuable inputs. Okay, right from the session 1, where quality outcomes and financial outcomes, we establish some sort of a clear understanding and also about innovation. I think this probably was the most engaging session, especially on design thinking, where we had people from, when we had speaker from Israel, and also Mr. Taylor talking and sharing, Mr. Hariharan sharing his views. And thank you, Mr. For navigating us through both these sessions, and also summarizing the outcomes of both the sessions. Thank you all the delegates for signing up and having a patient hearing. And with this, I conclude today's Quality Forum session. Thank you very much and have a good evening.
Thank you.
Thank you.
Thank you.